Dr. Sisk and I had the great fortune of spending some time with each other in medical school at the Cleveland Clinic, Lerner College of Medicine. And we went different ways. I kind of went the primary care route, and he's kind of gone on to do great things in the field of research, and we're going to hear a little bit about that today. After a medical school, Bryan headed to Washington University School of Medicine and did his work in pediatrics and in pediatric oncology, as well as work with clinical research with an emphasis on bioethics and advancing understanding of how we communicate with our patients, especially surrounding difficult conversations. So we are very pleased to be able to offer him this next hour-long lecture to kind of help us understand conversations that can sometimes be difficult for us. And I'd like everyone to give a round of applause for Dr. Sisk.
All right. Well, hello again. I'll put on my different hat today, I guess this hour. So I am really, really excited to be here and talking about my research on communication. Before I get into the presentation, I want to throw out two caveats. One is that most of these studies have been around cancer or serious pediatric illness, but I think there's a lot of lessons that we can learn and adapt to other serious illnesses, other difficult conversations. And what we perceive as a difficult conversation and what a patient perceives as a difficult or emotional topic might be very different. The second is that all of the things I'm going to say are in recognition that you have very limited time in clinic. And so I don't want you to take away from this that we need to spend hours doing these things. I want more so to think through how can we take what I've learned from these patients to make the brief moments that we have more purposeful. So with that, I have no conflicts related to this presentation. I have three main things I want to accomplish today. I'm kind of a history nerd too, and there's some really fascinating history about how we historically communicated with patients. So we'll spend a little time talking through our history of communication. Then I want to talk about some work I spent a couple years doing, kind of identifying a functional model of communication that reorients how we think about what we're trying to accomplish with patients. And then I want to end with some practical tips that you can take away, which are lessons I've learned from research and from patients themselves. So historically, physicians have been encouraged not to break bad news to their patients. In the 1840s, allopathic medicine was not the big dog on the street. It was fighting with homeopaths and Thomsonians and eclectics to try to have a stake and say that we are the predominant form of medicine in this country. And in part to consolidate their strength and in part to root out what they would have called quacks at the time, they created the American Medical Association in 1846. As they did that, they said, we really need a code of ethics that's going to guide us through how we should act as doctors. And it was an amazing form. When we think of codes of ethics these days, they're maybe 500 words, 1,000 words. This was about 15,000 words, and it got very particular about things even like where you should hang your shingle, how you should dress, things like that. They interestingly had a lot of detail about what we should do when patients have a terminal illness that they would have called at that time, which is cancer. And when the overarching theme was, in 1847, was don't tell patients. And so I'll read a couple of excerpts because I think they're pretty remarkable. They said, a physician should not be forward to make gloomy prognostications because they savor of empiricism. So don't tell the truth just because you're going to be a jerk that's going to focus on the truth. But he should not fail on proper occasions to give the friends of the patient timely notice of danger when it really occurs, even to the patient himself if absolutely necessary. So if you really need to tell somebody for some reason that they're going to die, don't tell them, but tell their family or friends. Or if you have to, tell them, but recognize the risks. And this was because the physicians were supposed to be the quote, ministers of hope and comfort. I think we like to think of ourselves as ministers of hope and comfort. But they say this office, meaning giving bad news, is so peculiarly alarming when executed by the physician that it ought to be declined whenever it can be assigned to another person of sufficient judgment and delicacy. So tell somebody else to tell them. And for the physician should be the minister of hope and comfort to the sick. And you might look at that and say, well, they were just trying to shirk their duty, or there was just different expectations or different cultural norms. That's all to some extent true, but it's also true that they literally believed that telling people they had a terminal diagnosis would kill them. And so later in the code, they say the life of a sick person can be shortened not only by the acts, but also by the words and the manner of a physician. It's therefore a sacred duty to guard himself carefully in this respect and to avoid all things which have a tendency to discourage the patient and depress his spirits. It's a noble approach to say, how do we make the patient feel as good as they can about their life? I think what we've learned since then is that the approach might be misguided, at least in our current times. I'm always hesitant to make judgments about past historical eras based on current historical norms. So that's just a really important thing to note. This is what it was. There was a lot of things that went into it. Things are different now. But this approach of not telling patients to protect them really persisted for a long time. So I've got a collection of different excerpts we'll pull from papers throughout different eras. And so this is a paper from 1909 that said, in regard to cancer, the consensus of opinion is that patients should be kept in ignorance of the nature and probable outcome of the disease as long as possible, so we can obviate the severe mental depression which invariably accompanies such knowledge. And then similarly in 1915, another physician said, it's not merely the danger of the fatal shock of the news that should restrain the physician from telling them they're going to die, but the almost certainty that telling the patient they're going to die is going to be the biggest obstacle to them having a cure. So again, this worry that people will give up hope and will die because you take away their belief that they might live. But it kept going. So in 1961, there was a study in Chicago where they went to a hospital and they asked every physician there, if your patient had cancer, which again at that time there was no effective treatments for, or very few, would you tell them that they had a cancer diagnosis? Meaning, would you tell your patients they were going to die? In 1961, about 90% of physicians said, no, we don't want to do that. 1966, Glaser and Strauss, who were really big social science researchers, they plopped themselves down in a Veterans Affairs office and just watched what happened. So the other interesting subtext here is a lot of this non-disclosure was related to patients that were kind of higher in society. The VA at that time was viewed as lower in society. And so there were less hesitation to tell people in the VA that they were going to die of cancer. So what Glaser and Strauss did is they just watched what are the different modalities, the different typologies, the different ways that patients are told that they have cancer. And often it didn't go well. I won't go through the full list, but one of them was a physician that came in and didn't say you have cancer. He just said, it'd probably be good to go home and get your affairs in order, and then discharge him from the hospital. My personal favorite was the very flustered surgeon that came in after a surgery, yelled, it's malignant, and then walked out. So it didn't always go well when we did tell patients that they had cancer. And I'm a pediatrician, so I want to go through a little bit of the history in pediatrics related to this as well. Nobody really thought about this. There's no publications about talking to children about death or their illness until the 1950s when psychologists started to explore it. So even though it was readily accepted in the 1840s that this is an issue for adults, for kids it wasn't really until the 1950s in the modern era that we started thinking about it. And pediatricians had a lot of reasons for wanting to protect children from learning about their diagnoses, and I'll go through a few with some exemplary quotes. So one was the potential inaccuracy of diagnosis. Back in the 50s and 60s, you weren't always sure that a cancer diagnosis was a cancer diagnosis. And this physician said, without an accurate diagnosis, it's cruel to arouse anxieties unnecessarily. If you don't know for sure it's cancer, you better not scare people into thinking they're going to die. Then there were concerns about the harms of truth. And this is a really remarkable example of an experience one physician had. He said another boy who was 15 years of age who had leukemia that was in remission was being discharged, and on the way out found out that what leukemia meant, that he was going to die. And he solved the problem by leaping from his 8-story hospital room. So this physician was clearly worried that he was causing people suicidal thoughts by telling them. And there was this pervasive belief that kids didn't want to know. This physician said, children observed by us rarely manifested an overt concern about death. Our suspicion is that this does not reflect an awareness, but rather represents an attempt at repression psychologically concerning the anxiety around death. So the thought was that kids aren't asking us these questions, so they're probably trying to repress it, and we should respect that repression. We'll talk about how I think that was well-intentioned but misguided. And then there was this concern, which is true, that the disclosure affected the family. And this physician said, we're concerned about the effects that this revelation of the diagnosis might have on the relationship with the parents, the brothers, sisters, relatives, playmates, and classmates. So these were the main types of arguments that were proposed kind of between the 50s and the 70s to say we should really withhold this information from children as well. But it gets a little uncomfortable because sometimes there were things that even back then I think should have been viewed as unethical. Some physicians were openly advocating for deceiving their patients. And so this example was a physician who was writing an article extolling their approach. And he said, "We recently had a 13-year-old boy with lymphosarcoma who had a frozen pelvis and a functioning colostomy. He'd been told that he had a draining abscess from a ruptured appendix, and as far as we could tell, we felt that he accepted this diagnosis as correct, and we never intended for him to know otherwise." So you have a kid with cancer that's dying, and you tell him, "Nope, you just have an abscess, you're going to be fine." This approach started to change in the 70s, and the first signal of this approach kind of manifesting more broadly in medicine to more disclosure was this study in 1970 that was published in 1979. If you remember that study in 1961 where 90% of physicians said, "I don't want to tell my patients that they have cancer," they went to the exact same hospital about 18 years later, gave the exact same survey, and at that time about 97% said that they would tell their patients they had cancer. Part of this was because we started to develop some treatments for cancer that were more efficacious, but part of this was because there were big cultural and social changes, like Kennedy assassination, another Kennedy assassination, Martin Luther King assassination, civil rights movement, the anti-war protests, the women's liberation movement, the psychedelic culture, and this overarching concept that was pervading certain parts of society of questioning authority. And it became clear that physicians were viewed by some of these patients as the authority figure that they should rebel against. And so you started to see this pendulum swing where, looking in pediatrics again, by the late 60s to 80s, really by the mid-1980s, it had swung from don't ever tell kids to really very frequently tell kids. And part of the reason was because lying is hard. So children inevitably sense what's happening to them or in their family, even when deliberate attempts are made to shield them from the tragic, frightening, or complicated affairs. We might not tell them, but they know. And that became more and more apparent through research at that time. And the concept that children aren't asking questions because they don't want to got flipped on its head when people said, are we just creating an environment where it's really hard for kids to ask questions if they wanted to? And then lastly, there began to be a recognition that transparency supports many children and their parents in their relationship and in their care. So in order to help a child cope with problems of serious illness, it's necessary to develop an environment in which he feels perfectly safe to ask any question and completely confident of receiving an honest answer. What honesty means can be different for every situation, but what dishonesty means is usually pretty clear. So the pendulum had swung from never tell to always tell, and in recent years it's kind of fluctuated in the middle that we need to adapt to the unique family and patient needs. Never having dishonesty, but adapting our approach to what the patients need. And so now I want to move from the history up to some of the current work that I've been doing. Learning that history is what really got me interested in studying this field. And then at about 2016, I started to figure out how I could jump in and actually do research. And it occurred to me that I didn't know what we mean when we say high-quality communication. At that time, we knew from the literature, about 20 years of literature at that point, that what we consider high-quality communication could lead to things like patients feeling less regretful, having more comfort, more trust in their physician, feeling like they're a good parent or a good patient, feeling hopeful. We were starting to see some health services benefits, like less requirements for ED visits, improved satisfaction in care, better self-management. A lot of these things were starting to pop up, but it still remained unknown what we meant by good communication. And there were two main approaches to the research on communication. One was focusing on very specific aspects, narrow, important, specific aspects that don't encompass all of communication, like making decisions around end-of-life care, disclosing prognosis, managing emotional distress. And then other studies focused more on just an overarching concept of high-quality communication. But I trained as a basic scientist before I became a social scientist, and so I'm a big believer in model systems and patterns and structures of how we're going to approach things. And so I thought if we want to intervene to try to improve communication and care experiences, we need to know what we're measuring so that we can tell if it changes. And if we want to measure, we need to know what communication actually means that we're trying to measure. And so that's what I'm going to talk about here for the next few slides, is a couple of years of work of defining what does communication mean. Often when we think about communication and we think about workshops any of us have gone through, communication is often thought of as a process. And I'm going to propose that that can be useful at times, but it might be more useful to think of it as a functional model. A process model says if you want to improve something like communication, you need to follow specific processes. For example, if you want to improve the way you respond to emotions, you should name the person's emotion out loud to them. That's a process you can follow. You can measure if people are doing that. You don't know if that's actually helping every patient, though. You should help the patients to ask what-if questions, explore uncertainties, giving prognostic information explicitly and clearly to every patient. These are all processes that I would say probably would help the majority of patients, but won't help all. What I like about functional models is that they say to improve communication, you need to ensure that you're fulfilling core functions of what communication is supposed to accomplish. In other words, you can take many different paths to the same goal, and we'll go into a little more detail about what that means. Functional models have benefits in that they can be adaptable. If you have a process model that says you need to specifically address and name an emotion to a patient, there's going to be patients that won't be helpful for. If you say that we need to figure out for this particular patient how to support their emotional needs, then you can adapt that to what their emotional needs are and what their particular interactions are like with the physician. The reason this really stuck out to me is in one of my studies, I asked a 21-year-old young man who had just survived cancer, I said, when is the time that a doctor did a really amazing job kind of responding to your emotions? And he said, I can tell you exactly the time. I had just been diagnosed with cancer. They came in, told me my prognosis, told me about my surgery, told me about the amputation, what short-term risks, long-term risks were going to be, and it just hit me, like a bag of rocks, and I just broke down and started crying. And they did the best thing they could have done. The nurse that was in there didn't look at me, didn't touch me, didn't say anything. She just got up and left me alone. When he told me this blew my mind because everything in the literature says that's exactly the opposite of what you're supposed to do. And I don't condone that for the vast majority of patients, but it points out that for this particular patient, following our standard process of what we're supposed to always do would have been a disservice for him. And so how much better if we can figure out what he might need or be open to adapting our approach to him. The other thing is that families know when you're insincere. If you go into a room and try to follow a process that's not true to the way that you communicate as a human being, it's going to seem plastic and fake, and it can be insulting. So I was able to build off of some work that they had done in adult oncology where they developed this functional model of communication. And it had 6 different functions that were all interconnected that are things we're trying to achieve when we talk with patients about about cancer, but I think it also applies to other serious disorders as well. And so starting with that, I wanted to know how does this apply to pediatrics? And so we did this multi-site study where we did semi-structured interviews with 80 parents, focus groups with 59 clinicians, and then structured interviews with adolescent and young adult patients who were between 12 and 24 years of age across these 3 sites. And what we found, I'll just summarize about 2.5 years of work in one slide. But we found these 8 functions that are the core of what we're trying to accomplish in our interactions with patients. And it included enabling self-management, exchanging information, managing uncertainty, responding to emotions, building relationships, making decisions. Those all were similar to what they had discovered in adults. In pediatrics, we found additional evidence that providing validation and supporting hope were especially important. Providing validation for the patient when they're an adolescent or a young adult, helping them to feel like they're growing into an adult, like they have a voice, like they're not only their concerns are taken seriously, but that they are taken seriously was really important. And for parents, this concept over and over again came up of helping them to feel like a good parent, because I'm a parent, and when my kids are sick, I feel like I'm failing because my job is to protect them, and my kids have never had cancer. So there's this deep-seated fear that this is my fault as a parent or I'm not fulfilling my duty. So whatever we can do to help parents feel validated in their role can be monumentally important for them. And hope, again, important, and hope can mean different things to different people, but giving them some sense of hope that's an honest hope of what they can expect, but what's the best that they can expect, but what's the worst that might happen. And we corroborated this in different populations, and we've just started some work with a publication that'll be coming out in a couple weeks that's looking at how adolescents and their parents are navigating these different roles in cancer. But that's the kind of theoretical background. And what I want to do quickly now is just jump into bad news breaking. And so I want to focus on two functions, exchanging information and responding to emotions, to give some practical tips that I've learned. When we talked about exchanging information in our model, parents brought up things like accurate information, adapting to their unique informational needs to make sure it's understandable, making sure it's transparent. And we did another survey study where we found that even with bad prognosis, 90+% of parents said that it was very important to have all the details about prognosis. Same for late effects, long-term side effects. We found a similar thing with adolescents and young adults. They want to know this information. 2 points on this. One, 84 to 87% is not 100%. So that still means 10 to 15% of these patients don't, and you have to figure out how to meet them where they are. Number two is that not all disclosures are the same, and some people want to know in vague terms, some people want to know in more discrete, explicit terms. But this wasn't just about prognosis and side effects. In a Swiss study, 86% of parents said that they didn't get information about how their disease could affect psychosocial health. So again, if there's psychologists you're collaborating with, or if you have any other resources, that can be really helpful for families as well. But along with this, it's not just what we're communicating, but how we're communicating. Patients want understandable, sensitive, honest, appropriately paced information, and they want it to be adapted. And so these are just to run through a couple of things that it might be useful to just ask patients when you're going in. Rather than saying, I'm going to tell every patient percentages if it's a bad diagnosis, maybe ask them, do you like percentages? Do you like details, or do you just want to know generally easy to treat, hard to treat, good outcomes, bad outcomes? Do you want all the information up front? Do you want me to pace it? How much do you think your child wants to know? How much do you want your child to know? Should we tell you together or separately? And does this change over time? For some families, what they need at an initial diagnosis with a serious illness is different than what they need a year after. You could look at this and say that's a lot of time, but I think it's just potentially just a different use of the time. And short investment early on can save you a lot of re-explaining later on. And this is just some tips from adolescents and parents when we ask them for advice to clinicians about giving information about a bad news. And the things they said were, try to assess the emotional state if you can before you give information. If you just told somebody they have cancer, that might not be the time to give them 30-year outcome data because they're not going to absorb it. But using simple terms, remaining open to their questions, encouraging questions that maybe you can't answer in the visit because of time, but that they could come back with later or find another means of getting answers to. And then asking what they want. That's the big thing I've learned, is trying to just learn from the families where they're at and what they want at that moment that I can try to help with. And then quickly thinking about responding to emotions. Really, we found there's anticipating emotional responses and then responding to emotions that are there. Believe it or not, emotions are everywhere in difficult encounters, in difficult conversations. So we did a study where we audio recorded 35 clinical encounters between clinicians, parents, and children after a relapse of cancer. 91% of these encounters contained emotional cues, which are kind of subtle hints at emotions. And then 40% contained explicit emotional concerns, where parents said something like, I'm scared, I'm angry, I'm anxious. Only 3% of children had cues, and no child in the study had any explicit concern. And the other thing to note is, so the takeaway from that is that a lot of these cues, a lot of emotions are going to be subtle and under the surface, and kids are often not going to feel empowered to raise their concerns up. The other thing is parents put on a happy face. So they did a study in 2013 where they had video of parents, and they had somebody go in and rate that parent's affect. Do they look like, from the interview, does it seem like they're happy? Does it seem like they're sad, et cetera? And they had that expert interpretation of their physical features, and then they had the parent fill out a form saying, am I happy, am I sad? And they found that it was actually inverse. The parents that seemed happier on the outside were more upset on the inside. So we cannot rely on the way parents seem on the outside when we're talking to them as a true interpretation of what they're feeling on the inside. And then in adolescence, there's this concept of mutual protection, where sometimes adolescents will want to protect their parents' emotions, and parents will want to protect the adolescents' emotions. And because of that, it really is useful to find some psychological support for them to help work through that, because we have neither the time nor the expertise to work through those complexities. So responding to emotions requires choices. And when there's a choice, it doesn't often mean more time necessarily. So this was an excerpt from one of our papers where a father was talking about a surgery, and he said, God, just the thought of putting her through 3 or 4 hours of surgery is just, ugh. And he trailed off. And at that point, there was a choice. You could have a technical response where you said, well, this procedure is actually really safe. The surgeon's very experienced. I've had a lot of patients get it. It's going to be really should be really fine. Nothing wrong with that response. There's also more of an inquiry response, an inquisitive response. You say, I can see that you're upset about that. What is it that worries you about the surgery? And they might bring up something that isn't what you expect. That you might think that they're worried about the competence of the surgeon. They might be worried about the IV that's going to get placed while the kid's awake. So sometimes the emotional inquiry can help you from not explaining something that they don't need explained. What I can say from my personal experience as a doctor and as a husband and my literature review and research is that we are problem solvers. When we hear something, we like to jump to a technical response because we see a problem, we fix it, we can move on. Sometimes for some patients, it might help to just have that one open question that might open up to guiding us to helping them better without wasting time. So the key takeaways are that emotion is often subtle. Parents often offer hints, children are seldom involved, and clinicians, we often want to respond with information where it might be better to respond with a question, at least up front. And, I'm not in love with mnemonics and processes, but sometimes they can be a helpful starting point. And so this is what's called the nurse mnemonic, which is when you see a patient is upset and you're not exactly sure what to do, you can sometimes start by naming the emotion, just saying, seems like you're upset or seems like you're worried, trying to understand their core message. What is it that's worrying you? You're respecting and reassuring that it's the right time, at the right time. Now that we've talked about this, let me tell you why I think it's going to be okay. Providing support, exploring, etc. The thing about mnemonics like this is if you start by naming the emotion and you get a response you don't expect, jump off the train. Individualize your care. If you're talking to that 21-year-old and he's like, I don't want to talk about it, say, great. Let me know if you do. I'm just going to give you some space. Would that be better? So it's not that you have to get from N to E. It's that you try and you be responsive, just like we look for subtle murmurs when we listen with a stethoscope. Look for subtle cues to see, are we giving this patient what they need, and how can we best use our limited time with them. In summary, what I would say after a few years of research on this is that the best recipe for success that I found in communication is having a humble curiosity, recognizing that you don't understand the patient's experience and that you want to learn about it, intending to communicate well, just saying, I want to do a good job for them, because that intention will come across and will build trust, and then being attentive to subtle cues. And with that, I just want to pause, thank my mentors, my collaborators, my funders, and then pause for any questions that people might have. Thank you.
Do we have any questions or comments from the audience? So I do have a question for you. So when we're having these conversations, they'll vary. I mean, so they're not always like cancer level. Sometimes, for me personally, hey, you may miss the championship game. And that, some people can take that as devastating as if it's a fatal diagnosis. And how do you, I wonder, do we ever catch ourselves thinking, this isn't that big of a deal, but the patient's kind of on a different perspective. How would you address this when you as the physician is thinking this isn't as big of a deal as the patient is making it out to be?
Yeah, that's a great point. Are we always on the same wavelength with our patients? The answer is sometimes yes, sometimes no. I'm a pediatrician, and when I was in residency, in winter months, RSV after RSV after RSV admission, you go in and tell the family, it's RSV, we're going to need to admit you, we'll put them on some oxygen for a couple of days and they'll be fine, they'll get out. For us, it's like, all right, this is my 20th admission today with RSV. For that parent, it's, I've never had any problem with my child, this is the worst day of my life. And so, absolutely, recognizing that we don't understand the perspective of the people across from us unless they're trying to explain it to us. So I think that's where that concept of kind of a humility to know that we don't always know what the person is thinking, and then curiosity to treat it like any other diagnostic approach we do, to say, I wonder if this is my preliminary diagnosis, is that they're not going to be upset about this. Let me test that out and see if I'm getting some feedback that confirms that.